Hi, my name is Simon Raphael. I'm the Chief of Pathology and the Director of Laboratory Medicine at North York General Hospital here in Toronto, and I'm an Associate Professor of Pathology and Lab Medicine at the University of Toronto. Repeat biopsy is an evolving area where practice patterns are just being established in line with new advances in technologies in medicine. Although a repeat biopsy may be useful in identifying changes in tumor characteristics, it does carry a risk of complications, which patients and their physicians usually like to avoid. In lung cancer, a repeat biopsy can be hindered by the location of the tumor and the accessibility of the lesion, and as a result, it is not performed as often as in other cancers, such as prostate cancer. However, there is a need to establish whether a new mutation may respond to new agents that has occurred in a tumor. This need is bringing about a change in practice and leading to investigations into non-invasive procedures, such as liquid biopsies. Another reason for performing a repeat biopsy after relapse on EGFR TKI therapy is the occurrence of phenotypic changes in the tumor, such as the presence of small cell carcinoma or the presence of an epithelial mesenchymal transformation. Liquid biopsy in oncology is an exciting technology that I see playing a role in lung cancer as well as other tumors. Both circulating cell-free DNA and genetic analysis of circulating tumor cells are being actively explored. In patients with non-small cell lung carcinoma, liquid biopsy can provide the genetic landscape of all cancerous cells present in the blood and may play a role in determining when patients are actually in remission or decided to be in relapse. Additionally, during a relapse, the technique allows us to determine what percentage of circulating tumor cells harbor a treatable resistance mutation and to decide when to initiate therapy. Finally, liquid biopsy may prove to be useful in cancer as it allows for a collection of a sample of only the type of cells that are metastasizing. It also gives us an idea of the tumor as a whole rather than a very limited biopsy sample. Third-generation EGFR TKIs may offer new possibilities and alternatives to patients with non-small cell lung carcinoma who have developed resistance to earlier generations of these agents. They tend to have less toxicity and offer more inhibitory specificity when compared to previous generations of EGFR TKIs. Furthermore, third-generation EGFR TKIs may offer an alternative to traditional chemotherapy. Third-generation agents may lead to a better prognosis and may provide patients with advanced EGFR mutation-positive non-small cell lung carcinoma with more tolerable treatment options. The number of mutations that must be tested will probably increase in future, so I anticipate there will have to be a wider spectrum in our testing. As the cohort of patients who have been treated for a long time increases, things like mutation resistance will become more of an issue, and we will have to work harder in order to deal with them as well. Ideally, labs will have to adjust to this rapidly changing field so they can keep up with which mutations need to be tested and ensure that information is reported in a clinically comprehensible and meaningful manner. I would also like to see more coherent funding for all genetic testing across each province. This must be a priority if we are to truly offer first-class healthcare to our patients. I anticipate that as time goes on, testing technology will become more standardized, cheaper, faster, and easier, and I hope eventually all thoracic centers will be able to do their own testing for lung cancer. Last, I hope that my fellow pathologists will recognize that these tests are the future, and that they will make these tests a part of their routine practice. They need to be as involved as possible in the organization of these methods, so that we can provide patients with a complete picture of their cancer, in other words, truly personalized medicine.